It is unusual for a diabetes medication to garner as much discussion in the anesthesia community as the mainstream press, but that has been the case for the increasingly popular GLP-1 or Glucagon-Like-Peptide-1 receptor agonists. These medications, first approved for the treatment of type 2 diabetes, are not an entirely new class of medications. In 2005, twice-daily exenatide, or Byetta, was approved, with once-daily and once-weekly versions following. Much of the recent interest in these medications is not related to their early versions, but instead the newest iterations. Perhaps one of the best-known GLP-1 receptor agonists, semaglutide, also known as Ozempic or Wegovy, received significant attention after the results from the 2021 STEP 1 study were published, which showed users lost an average 15% of their body weight over a 68-week period. This degree of weight loss was previously unheard of outside of bariatric surgery. The latest version, a dual GLP-1 receptor agonist, GIP agonist, tirzepatide, or Mounjaro, has demonstrated even greater potential, with users losing 15 to 20% body weight, according to the SURMOUNT-1 trial. However, these medications do present risk in the perioperative period. Because these medications replicate the action of GLP-1, a gut-derived incretin hormone that delays the excursion of glucose from the stomach into the duodenum, they can similarly result in delays in gastric emptying. There have been several cases in the literature of patient complications related to gastroparesis and GLP-1 receptor agonist use. In response to the widespread discussion about the risks these medications pose, the ASA recently released a consensus-based guidance on the preoperative management of patients taking a GLP-1 receptor agonist. If a patient on a once-weekly version does not hold their medication 1 week prior, as the guidance suggests, gastric ultrasound can be used to help further patient management. Gastric point-of-care ultrasound, or POCUS, is a simple, easily reproducible tool for assessing the presence and nature of gastric contents. It allows for both qualitative and quantitative assessment of contents. An empty stomach can be recognized by its collapsed bullseye appearance. Clear liquids will appear as dark black hypoechoic content, whereas solids will appear more hyperechoic, with air appearing as the brightest white hyperechoic content. The exam can also be used to distinguish between baseline gastric secretions and a larger volume of liquids that puts the patient at an increased risk for aspiration. This is a gastric POCUS exam from a patient taking semaglutide. They are 8 hours fasted from solids and 2 hours fasted from clears, but despite that fasting interval, there continues to be the presence of solid, liquid, and air content on exam, as visualized above. The promise and potential of these medications is difficult to overstate. In addition to their impressive efficacy as treatments for diabetes and obesity, these medications have demonstrated significant future potential for the treatment of addiction disorders like alcohol use disorder. Anesthesiologists will continue to encounter patients taking these medications in the perioperative period. Gastric ultrasound offers a quick, reliable, and reproducible method to thereby risk stratify patients and provide them with the best possible care.